Buenos días. La siguiente ponencia va a tratar sobre la enfermedad ósea metastásica en el cáncer de próstata, a cargo de la doctora Tunariu. Ella es radióloga del Hospital Royal Marsden del Reino Unido y está especializada en imagen oncológica, sobre todo en resonancia magnética con difusión de cuerpo entero y carcinoma de próstata, y es autora y colaboradora en múltiples publicaciones. Es un placer para mí como radióloga presentarle y escucharle.
No, I speak very loud. So good afternoon. I'm sorry, my Spanish is very bad, so it will be in English. But please do come and find me after for questions if it's helpful. I'm going to talk only about bone metastasis, because I think this is the biggest problem in prostate cancer. And now that you have more therapies for prostate cancer and we see more young patients with prostate cancer, I think we need to address it. And I'm going to start with the first patient that made me go on this journey. This is a gentleman, and I put there an elephant. I don't know if in Spanish is the same, but in English is every time you see a patient with prostate cancer in your room, to me, the biggest elephant in the room is when the patient is going to ask, has the cancer gone to his bones? Because we know it's the most common site of disease, and in terms of imaging, is the worst imaging we can do. We can't do worse than what we do. So there we achieved some negative outcome. So this is a patient who was on M0 treatment and came with a PSA of 7. Everyone said, well, it's fine, it's a PSA of 7. The CT and bone scan were reported negative. You send him home and say, come back in 3 months. At least that's what we do in UK. He comes back in 3 months. The PSA is now 34, and I'm sure all your patients are very worried. And regrettably, the bone scan and CT are negative. I went to a professor of nuclear medicine, and he agreed. So you send the patient away and say, well, maybe, who knows, it's nothing to worry. The patient comes back in another 3 months, this time PSA it's 100. Now the CT and bone scan are still negative. And I promise you, you are going to have these patients more and more because they live longer and they will come to you. That's when I was starting, it was like 7 years ago, to do diffusion-weighted imaging, and this is whole-body MRI with diffusion-weighted imaging. And, And what you see here, all of these black dots, I just inverted the images, are bone metastasis. And this was here, and this was here. So you have a PSA of 100, around 50 bone metastases, and a completely negative CT and bone scan. And to show you the pictures, while you are waiting for the bone scans to appear on a bone scan, bone lesions, your patient develops dramatic progression. So it goes from a 5 millimeter or 10 millimeter lesion to entire involvement of the vertebral body, and the same here. So at every single level, the tumors are doubling in time. And what I ask my clinicians, if this will be liver lesions, you'll be very worried. But because these are bone and you don't see them, you are very happy to say, patient is not symptomatic, let's continue. And I think, personally, that this needs to change. Finally, the patient developed a PSA of 150, and the bone scan reported small volume bone metastasis. So this is the reason I think that the MRI is going to play a dramatic role in the bone metastasis. Now, this happens at every step in the journey of the patient. This is a small study of a prospective data in which they show that if you take a high-risk prostate cancer patient and you do a bone scan, in 20% of those patients, not only that you are going to find one metastasis, you are going to find numerous bone metastases, and you are going to deny those patients appropriate treatment. Most important, and this is where we have a problem as radiologists, which imaging method you use, you are going to have more or less bone metastases. And when we talk about M0 clinical trials, we should always say what M0. Because if you put in your trial bone scan, you are going to contaminate the data. If you put in your patient in your trial colon PET, you may miss some of the data. If you put in your trial natrium fluoride PET, which is like a bone scan on steroids, very, very powerful bone scan, you may overcall the data. So that's why it's important that you involve a radiologist, and you need to try to be as consistent as possible. And for me, there is now a lot of discussion in the drug companies about what imaging should they use if they really want to do treatment in so-called M0, which we don't know if exists, in fairness. We know it is important, and everywhere you look, the metastatic bone disease is the dominant site in prostate cancer. It is associated with a higher mortality than patients with no disease. This is in blue, this is in green. And more importantly, up to 0.5% of your patients are going to have bone-only metastases. And the other important myth we need to go away from, the bone metastases in prostate cancer are a very complicated process. You have at least 4 players. You have osteoblasts, you have osteoclasts, and you have mineralized bone matrix. So you have a complicated environment in which you are going to have not only osteoblastic lesions as you are used to, and in fairness, in this patient, what you see there is scarring. He has widespread metastatic disease, but what we see on CT, it's only the areas of scarring. Patients like this one, in which you may see that he has core compression because the disease is very lytic and it's coming out of the bones, or patients like this one, in which the disease is completely lytic. So the metastatic bone disease in prostate cancer, it's very variable, and you need to be aware, and in the future, you may need one then more imaging method if you really want to treat these patients. Again, we have very suboptimal imaging in our current practice. If I will ask you, how many bone metastases do you think this patient has? And make a mental attitude, because I'm sure you look at the images. Well, I'll tell you that he has around 50. Can you see them? Well, the bone scan shows them, and then the patient comes back and responds to treatment, and you are going to see them. So what you see on this follow-up scan, it's no progression. What you see, it's patient having a dramatic response. And finally, you see the scarring. And that's how you see pre-existent bone metastases. So please, if a CT is negative, it doesn't mean anything. The patient could have 50 lesions, could have 2 lesions, or could have no lesions. What about bone scan? How many of you are going to deny this patient radical treatment based on this imaging? Which one is malignant and which one is benign, do you think? And again, make a picture in your image. The patient comes to the clinic, this is what you see. Well, it just happens that the patient has a benign enchondroma and had surgery for his heart and developed osteomyelitis. So he has scarring. So it is incredibly important that if you are going to treat the patients with prostate cancer more accurate, that you get a radiologist or you get the knowledge, because all these imaging techniques have a lot of weaknesses and strengths. And we are going to damage the patient. So a positive bone scan doesn't mean those are metastases. It's the way we are, and we just need to get better in this field. And it is a plethora of tracers that are going to come to you. This is bone scan versus PSMA. Again, you can see, when you see these kind of images, you realize that some of your patients, you really did not help them. This is another one in which, it's flucloxacillin. This is used in the States. Again, there are variables. The most important thing is this. Every single imaging method, it's better than bone scan, but be aware that every single imaging method has false positives and negatives. I'm afraid, like the histopathologist said in the morning, there is no perfect test. We will just need to learn together when and how should we change the treatment for our patients. Most important is, please remember, imaging never tells you that the lesion is cancer or not. Imaging just says this lesion has a certain property which is maybe more common in a malignant setup than benign. That's all. So a bone scan is not going to tell you that the lesions are metastatic. A bone scan is going to tell you this lesion has osteoblastic reaction. So a fracture has osteoblastic reaction. Degenerative disease has osteoblastic reaction. The CT is a little bit more helpful in that when you see a lytic bone lesion, Most of the times when you see bone destruction, that's not benign, unless the patient has osteomyelitis, but you may know. The MRI has been a gold standard for a long time for bone marrow, and you know that. The PET tracers are amazing tools, but please remember, it's about tumor biology. So a tumor may have the right to be PSMA negative and FDG positive. Doesn't mean that the test was wrong. You were wrong interpreting the test. You need to understand what each imaging method is telling you. So that's why I'm saying is, rather than having a war, which one is better, whole body MRI, PSMA, PET colon, you need to see what you have available in your hospital, what expertise you have, and make the best of what you have. But no matter how you put it around, you will need to find a way to replace bone scan. We are damaging our patients, and I am not so worried about someone who is 80 and has a slow growing. I'm talking about the 15% of the patients who are 50 or 60, have a Gleason 9, and they die under our eyes because we are waiting for them to become symptomatic, which will be too late for anything. Even if they fly to Memorial Sloan Kettering, will still be too late for them. So that's what I will say. It is important to remember it's very heterogeneous. So this is a beautiful paper illustrating that. If I will ask you which one of those lesions is alive, which one is dead, what one is scarring, just abstain. You will be wrong in all cases. So I will just say in my reports, patient has sclerotic bone metastasis. Stop. Are they progressing? Are they responding? I don't know. And that's the reality. If you've done an FDG PET, you may say one lesion is alive. You do an FDHT, which looks at the androgen receptor, well, you may say, well, there are many more. What is right, what is wrong? Probably the patient has all of them. Who knows? We need to do a little bit more work into this. But as I said, you need to be aware that this is the limitation of what we are doing now, and some of these images are going to tell us. So for example, if you want to give someone ADT or abiraterone or ENZA, you may want to choose this patient, isn't it? If you want to give him carboplatin with cabazitaxel, you may choose that patient. I don't know. Those are the trials we need to do, rather than doing trials with expensive drugs, including immunotherapy now in prostate cancer. And the only thing we do in radiology, we count bone lesions. Does the patient has 2 new bone lesions or it doesn't? That's all we do now. So I think we need to move on. Just to remind you that you have this heterogeneity. So the APCC at St. Gallen, I don't know how many of you have gone there, have been there. They are talking about the fact that we should try to spare futile treatment. But how many of you have kept a patient on abiraterone for 7 years with rising PSA? Because you didn't know where the patient was progressing. And even if I tell you where he's progressing, you will say, well, but how do you know that abiraterone doesn't do something? We don't. We just keep the patients because you are all used to treat the patients based on your gut feeling. If you will be a colorectal cancer patient, you will not do that. You will do an FDG PET and MRI liver, you will see the liver lesions grow, and you will stop the therapy. But in prostate cancer, we are used to look at the imaging just more like, well, stable, let's continue. So I don't know. This is a paradigm which will need to change. So this is my normal day-to-day work. This is a patient, comes to your clinic. This is the patient. You read this bone report, bone scan report, which says obvious progression. You have a radiologist which perhaps it's less experienced in metastatic disease and decides to measure sclerotic bone lesions. Please never, ever measure them, and says progression. What do? Stop treatment? You may say the PSA helps you. Well, the PSA is going up. So the patient has no pain. The patient is feeling great, but you have all of this. And I'm sure that any of you have been in this situation. And the important thing is to remember we have flare in everything. Bone scan, CT, PSA, PET, and so on. And that's why I like MRI, because MRI doesn't have flare. It doesn't care about all of these flare situations. And it is important to remember that we all know that we should never use bone scan, PET scans, or plain films to measure bone lesions. It's just sometimes we forget. And the only lesions we can measure are the lytic bone lesions. And that's why we have this. And any of you who've done prostate cancer clinical trials, this is what we do. Count bone lesions. So this is what I do at least 50 times a week. Really boring. I promise you, it's like a competition. Who gives more, who gives less? Anyway, first thing, the patient comes to you, has 2 bone lesions. What do? Well, it could be flare. So you wait. If the patient has no more extra lesions, then this was flare, was no progression. So therefore, you forget about the scan. This becomes your new baseline. Then the patient has more lesions at week 37. Now you are very worried about the patient, but if you really want to do the trial, you need to wait and do yet another bone scan, and then you will confirm progression. So this is all we have. And you may say it's silly and stupid, but we are so desperate in bone metastasis that this imaging, as crude as it looks like, works. Because if you look at this graphic, you may see that the patients who had 2 + 2 lived less than the patients who had no new lesions. So this is the reason why every time you read a clinical trial in prostate cancer, remember that 50% of the data comes down to had your patient had 2 new lesions or not. That's what it is, radiographic progression-free survival. Because remember that the greatest majority will have bone lesions. The only way you can do radiographic progression-free survival is by doing bone scans. And that's the reality. So these are some data. Now, why I don't like the bone scan alone is please ignore, and if someone comes to you with a partial response on a bone scan, again, ignore the result. You cannot do that. There is no such thing. There may be improvement on bone scan, but you need to have a CT or MR, ideally, to confirm it. So if a patient comes with a partial response, what should be at the back of your mind? A bone scan tells you about osteoblastic reaction. Now, what are the situations in which the osteoblastic reaction goes away? The tumor has gone, or, like in this case, the tumor became lytic. And the patient had a dramatic progression and ended up having radiotherapy because his sacral root here is completely compressed by disease. So that's why, for me, partial response on a bone scan, I'm always a bit, let's see the CT first. Make sure that your patient did not develop lytic disease. Now, the same rule is not going to help you in these patients. And these are the patients, I call them, we give them homeopathic radiotherapy. We bring them in hospital, we do a CT. This patient had 2 years of CTs like this. You do a bone scan, 4 hours, it will never change. You do an MRI, it will never change. Why? Because the patient has diffuse bone marrow abnormality. So unless you use a functional imaging, like diffusion-weighted imaging, these patients, we have nothing to scan them. We can't use PSMA for response, at least when we use androgen blockade, because right now we don't know. In some of the patients, PSMA goes up. In some of the lesions, it goes down. So no one knows exactly. So use PSMA for detection, but for response, be careful. This is diffusion-weighted imaging, and I will not spend a lot of time, but the most important thing is the same sequence you use for MRI prostate. i.e. is the sequence we look, how much can you move? So if you are in a cellular environment, i.e. a lot of cells, you are going to move very little. If you are in a treated tumor, you are going to move a little bit more, and if you are in water, you are going to move freely. It's a simple technique. It can be done by any scanner that has been bought in the last 5-10 years. More importantly, you have a measure which is very reproducible. So if you scan a patient today and tomorrow, the measurement will be 10% variation. To show you an example, if you use this technique, this is what you are going to see in your clinics. The patient comes to you, and his prostate tumor did not care about the radiotherapy, did not care about abiraterone, it decided to grow. But his metastatic bone disease did the opposite. And you can see here, the ADC, it's very high. This is a highly cellular tumor. This is a dead tumor. And this is what you are going to see in your patients with treatment. And that's why the PSA sometimes doesn't help you. Because I have no idea which one of these lesions secretes the PSA. Is the prostate progressing or is the bone responding? So this is what we do when we do whole body MRI. We do the same thing. We take 2 time points or 3 time points. We generate the images. All these bright points look like spleen. So in MRI, the tumor looks like spleen. Why? Because it's very cellular. So that's kind of what we see. And then we can do images like this, in which my radiographers look to make sure that we don't miss core compression. But I want to show you a comparison. Why doesn't work the bone scan? So here it is. We gave radiotherapy to the patient. This is a very high ADC. You see, it looks like your bladder. That's a responding disease. This is how it looks on a bone scan. But what about this lesion? Well, this lesion looks like your spleen, yes? Where it is on a bone scan? In the same area. So the bone scan cannot tell you if an osteoblastic reaction is because the patient responded to therapy and in fact has a sacral insufficiency fracture, or because the patient progressed. And that's why the bone scan, it is so unhelpful in detecting response or progression. So if we come back to this lovely patient, look at the ADC. You can see how we went from a darker shade of gray to lighter shade of gray and even lighter. This patient had a dramatic response to chemotherapy. And I don't need you to look at the shades. You can look at the numbers. 900, 1300, 1600. The patient responded dramatically to chemotherapy. Now, in terms of cost, a bone scan is around, in UK, 80 pounds. A CT, it's around 350. A whole body MRI is 500. So in my hospital, this patient is neutral in terms of I do a 1 hour scan and give the clinician a response, or I do a 4-hour strip and tell the clinician, I don't know, I've just done a scan. So that's why in response assessment, this technique is going to become, I predict, incredibly useful in the years to come. And I want to finish with this patient. This patient is a colorectal surgeon. So he comes to you and says, I want my prostate out. I don't care, it's locally advanced. You are my friend, I'm a surgeon, I want it out. So you do. So the patient has an ileal conduit and a colostomy. And comes to you a little bit later, and you send him to your oncology friend, or you treat him, whatever you prefer. His PSA is 16. You do a bone scan, and you say, well, it's not so bad. You have 2 lesions. Let's do a scan. Patient comes back later. Everyone is very happy. The PSA is going down. But the bone scan shows you new lesions. And you are going to say, well, the PSA is going down. This must be flare. So you wait. And he comes back with even more new lesions. So now you know he has progressed. Look at his PSA. It's 6. Still much less. So remember that a third of your patients will progress despite of the PSA going down. Because it's like the patient I showed you first time. 1 lesion responds, 1 lesion progresses. Look at the MRI. So if you can play the movie now, the second one. So this is, that one, yes, perfect. So this is the MRI when you thought he had 2 lesions. So he had 1, 2, 3, 4, 5, 6. This is the MRI when you thought he was responding. He has 20. And the patient, by the time you were playing around with the bone scan, developed lung lesions. And in fairness, died a year later with a malignant superscan. But this is what I'm saying. Flare, it's we need to deal with, but sometimes it delays you saving the patient. And also we need to try and learn, what does it tell us when a patient has a very low PSA, but a lot of disease, or the other way around? So there is a lot of thought saying you have androgen-dependent lesions and androgen-independent lesions. So maybe the androgen-independent do not secrete PSA. So even for urologists, you are going to have patients coming to your clinic with a Gleason 10, with a negative CT and bone scan, and a PSA of 2. Now, 10–15% of those patients, if you'll do an MRI or a PET, it's going to be a very unpleasant surprise. Again, I had a patient 2 weeks ago. The PSA went down to 0, but the patient had pain. We did an MRI, and he had horrendous disease in his pelvis because the disease decided to be non-PSA secretor. So it is important to have that at the back of your mind. I want to briefly show you that there is some data. This is data we did to prove that indeed our MRI has histopathological correlation. So when you see an increase in ADC, the tumor is dead. This is data done by my fellow, and this is one of the trials we are running. So I'm trying to do it right, to do clinical trials to prove that the MRI indeed does what I'm telling you. It's very hard because the radiologists are overworked and they don't want more work. So in my country, I am begging them. I pay for the scans. I don't want them to report the scans. But they know that if they will open their hospital, the clinicians are not going to go back. And it's not only the prostate. The breast patients will come, the pregnant women will come, the children will come, and then the renal cell will come. So if you open this gate, the whole body MRI is going to take all your weekend's list. That's what's happened right now in UK. This weekend, when I go back, I'm going to have 20 whole body MRIs done in a weekend. But it is so useful for the patients that all my clinicians who went to whole body MRI never went back. But for a radiologist, it's a lot of work. This is a paper if you want the protocol, and again, if you ever want the protocol, I'm very happy to share everything I know, because it is a dramatic help for metastatic bone disease. It is really very bad what we do, and I personally can't look in a patient's eye and say, your bone scan is stable. The only thing I can tell them is I don't know. So thank you very much, and I want you to remember that the patients will come to you, because you are doing molecular testing, BRCA. You are having many more treatments, PARP inhibitors. You are doing fusion MRI for your prostate biopsies. But the patients are going to come to you with a PET done in Munich, with an MRI done in London, and I'm afraid you need to get used to it. I have now patients which I cannot put on a trial. Do you know why? They never had a bone scan. So I need first to do a bone scan and then put them on a trial, because the trials are still using prostate cancer working group, which means I need a bone scan. So we just need somehow to accept that this tsunami is coming. Like it or not, it's coming, and your patients will come and demand to have MRI or PET. Thank you very much.
Magnífica exposición, muchas gracias, Nina. ¿Alguna pregunta? Bueno, yo personalmente nosotros trabajamos en NOSATE con resonancia magnética with MRI. So my question is, so you talk about whole body MRI with diffusion, like a very strong and very potential technique, but we have some kind of resistance with the oncologist to do diffusion MRI in breast cancer. So what is your opinion about how can we convince them, or what should we do as a radiologist?
So for me, it's it's important that you have, I think that the major problem for MRI, can I press anything? Press something. Yeah, sorry. The major problem, did you want to go? Oh no, okay, sorry. The major problem for MRI is I think a lot of clinicians find it difficult. I'm sure all of you can look at a CT, a bone scan, or a PET. For an MRI, you will need your radiologist, I'm afraid, because we haven't yet found a way to show you the data in an easier way, like maybe in color or... So I have clinicians who are telling me that unless you are around, I'm not going to request the MRI because I need you there in clinic to explain to me. So that's one reason. But I do promise you that if I would suggest the way we started in situations in which we really don't have a choice. For example, patients with malignant superscan, you know that your CT and bone scan are never going to help you. So in those patients, you may want to start doing whole body MRI. Patients who have a very low PSA, you know that you are not going to have the PSA helping you. You know that probably they have aggressive disease. And most of the time, they are young. And in those patients, again, the whole body MRI is going to guide you. If you want that patient to have docetaxel, cabazitaxel, abiraterone, and immunotherapy or radium, you need to keep him fit. The other thing we do a lot is patients who are, for example, in their 70s or 80s, and you do not want to give them chemo because the patient is too old, it's frail, has hypertension, who knows. In those patients, we do whole body MRI to ensure that if there is one lesion growing faster than the other, which may put him at cord compression risk, we treat it, and the patient still stays on abiraterone. So there are a lot of situations, and my question is this: if you have a patient in which you really want to know what is the state of his disease, then a whole body MRI will help you. If you are a surgeon who wants to do nodal dissection, then a whole body MRI will not help you. For nodal disease, specifically nodes less than 8 millimeter, you need PET. So like everything, you need to see the question, speak with your radiologist, and make a team and figure out how do you start. What I promise you is that when you will start, you will not go back. I haven't yet had any of the clinicians. Of course, it's a matter of resources, and it's a matter of having MRI slots. So that's why I think you need to try to define in each hospital what are your priorities and how much you can do, because it does take 45 minutes of scanning time. Thank you.
Bueno, no hay más tiempo.
So they were running out of time.